right, testing 1, 2, 3. Okay, so I am. Okay, cool. I am recording this, so you guys can have access to it later. All right. All right. So from the last time, what nerve did we talk about?
Thoracic.
Okay, I need a little more specific. So the nerve. What is the name of the nerve? Long thoracic nerve. So Eric, you were close. So the muscle. Next question. What was the muscle that the long thoracic nerve innervated? It is an upper body muscle. Hannah, you should know this.
Is it serratus anterior?
Correct. There we go. Phenomenal. Good. All right. So, what is the function of the serratus anterior? This might be a little hard one. I don't think I explained it a little bit, but
It rotates the shoulder forward and down.
so it is a upward rotation. It does pull a little bit down, but the motion is like this. So it does look like that slight downward motion, but you're really an upward motion. It posteriorly tilts, upward motion. It helps with protraction, retraction of the scapula, and I believe it's like slight internal rotation of the scapula. So, good. Puntos, puntos for those who answered. Good job. All right, so the next nerve. Whoop, meant to change that. So this is one of these smaller muscles. Where is it? Oh, it's not on here. There we go. Subclavius nerve. So the best thing about this anatomy and physiology is all related. So it is under the clavicle. So this is the component here. So it derives from that upper neck area, and as you can see, it goes under the clavicle, hence subclavian. So we are looking at nerve roots between C5 and C6 for nerve innervation. So what does the subclavius nerve supply? Subclavius muscle. Not really a well-known, talked about, muscle anatomy and physiology, but it's important nonetheless because these are little muscles that when we're treating and evaluating and we're trying to see like what else can we do, these are little things that we can work on. Now this area, it's not just the muscle, but the area that we'll go into is important because you have several structures that go under the clavicle, which play a role, and I'll describe it a little later. So the subclavius, it originates at the first rib, as you can see. And then it attaches to the distal end of the acromion. Clavicle, excuse me. And pretty much what the function is, you are going to a downward motion and then forward, coming toward you. Motion for elevation, and it also helps with elevation of the first rib. So it is almost like a slight respiratory muscle. Well, I said this muscle is very small. This is like a very deep muscle. We call it, it is deep. Whenever we refer to something as deep, it means it's further back or behind of certain muscles. So this is deep to the pec. So pec major, pec minor, that we talked about a little bit before. It is behind. So what is this important? What is the other importance of this? So the function of the subclavius is to help stabilize the clavicle during shoulder and arm movement. It is also a protector of your subclavian artery, brachial plexus, and subclavian vein. So this muscle helps prevent that. So you don't want to get structures clamped down. I'm going to talk to you a little bit later, but there's a condition that can form if this space is impeded. So like I said, so the subclavian muscle helps, again, like I said, with the functional movement of arm movement, whether it's like above the head, forward, reaching back, reaching forward. Because I am going to talk a little bit about the components of the clavicle motion as well. And like I said, it also protects it. So it does have that, when there is some damage, that muscle helps. So this is the condition. So as you can kind of, oh, that went away. My line shifted. So you could see this little space. Not that big of a space, right? That is your first intercostal rib space. There's something called Sternoclavicular syndrome, also known as thoracic outlet syndrome. I'm going to give you a little idea of what this is, but another lecture I'll do is, later on, is about thoracic outlet syndrome. Not the easiest thing to really diagnose. It is slightly hard to diagnose depending on what's going on. Sometimes it's never true thoracic outlet syndrome, but what you're looking at is when this space starts getting clamped down, what is that going to impede? It's going to impede your arterial, venous, and your nerve complexes. So, as we were talking before, you may not get the power. It's not like you have pain, it's weakness. You could be subjected to weakness, numbness and tingling, pain with this condition. You could have, if your serratus isn't firing appropriately, like I mentioned before from the last lecture, your scapula might wing. You may have deficits in power. You get like that, the numbness and tingling in the fingers and hands and down the arm. So this is something where we want to make sure this is a spot. This is an anatomical spot. So the subclavius attached to the first rib. Sometimes the first rib is elevated. In PT, if we notice this, comparing from the right versus the left side, we want to get that rib down. We want to make sure that rib's not elevated because it's impeding the space, right? And listen, these are millimeters of movement. This isn't huge, but we want to create that motion. We want to create that space. So I was actually looking up a release technique for the subclavius. This is very hard to palpate. More or less, you're really just trying to get like under your clavicle, like in the front here. So as you're going, like I said, it's really like deep. It's really under here. There are some techniques on it. I haven't done it personally yet on someone, but it gets a little uncomfortable. But nonetheless, I have done a first rib mobilization to help free from space. But now I'm going to incorporate a little bit more subclavius muscle as well, especially making sure that's freed up muscle, that's not restricted. So biomechanics of the clavicle. So we're going to go a little more in depth with the mechanics of the clavicle, because if we know how the clavicle works, this is important when we're talking about limits in motion, and when it comes to stability and movement. This is a kinesiology / like arthrokinematics type sequence I'm going to go through. So listen, some of this terminology and stuff may seem very foreign, and it probably will. But don't get like too caught up with it. You'll learn this again, but I'm just giving you a brief overview. And the joint that I'm actually going to focus on is this area. Wow, that was horrible. This area here. So I'm talking a little bit about the distal aspect, but I'm more talking about this area here. So the function of the clavicle. So you have 3 degrees of freedom, and you have the function is to stabilize and also resist compressive forces. The way someone injures their clavicle is falling on an outstretched hand and also falling on the side of the arm. When we're talking about the degrees of contribution of movement, this region along here is up, pretty much it helps with clavicular elevation up to 90 degrees. And for every 10 degrees of glenohumeral elevation, there's 4 degrees of clavicular elevation. So as you're moving your arm up, this also here moves up as well. So technically, it elevates. I know it's going to sound a little off, but there's something called rolling and gliding that occurs. It is going to technically, it elevates here, but it also elevates a little bit here, but not too much. It's going to roll and glide. But the elevation still applies in this manner. Like I said, I apologize. Me trying to explain this is a little challenging, especially when I don't have certain things in front of me. But the gist is, if you can see, you have your superior translation, inferior translation. So, and then you have your medial and lateral translation. And then you also have an anterior to posterior. So when I say these motions, these are planes of motion. You have your sagittal plane, your transverse plane, and your frontal plane. So, if no one knows what that is, so you have a sagittal plane. If you were to draw a line through your body straight, that is your sagittal plane. Your transverse plane is your horizontal plane. If you cut yourself off at the torso and you have a line through it, that is your transverse plane. Your frontal plane is this plane right here. So a lot of these directions are associated with their plane of movement. So the medial, so the anterior posterior is more frontal. The medial and superior and inferior translation is more frontal. Anterior to posterior is more like transverse. And then sagittal is the lateral. Frontal is lateral. And lateral medial. Superior, inferior is sagittal. You know what? Let me get back to you guys on that. I apologize. This picture's a little tough for me to navigate at the moment. But I like calling it A to P and superior, inferior, lateral translation. Okay, so arthrokinematics. So it is the sternoclavicular joint that we are going through. The types of synovial joints. It is a synovial joint, and you have the rotary and transitory movement, as I mentioned before, your frontal, sagittal, and transverse planes. The shape of the joint determines how the bone is going to move. Something you're going to learn in anatomy or kinesiology, or possibly anatomy physiology, is your convex-concave rules. So concave is, you're talking about the joint as, the roundedness of the joint. Your convex joint is like this. It is accepting the joint like this. So this is your concave side, this is your convex side. So this is accepting the joint. Now, when you're talking about the area along the clavicle, the sternoclavicular joint, there's two different types of surfaces. You have two areas, the medial end and then the notch by the manubrium. This is the manubrium is an area in the sternum or near the sternum. You're also going to have disc. So we call it like a menisci, because you need to have some material that's going to help glide and keep congruent that region. So making sure, so as it's moving, you're going to see that fiber disc is going to move when you elevate, depress, protract, retract with the shoulder movement. So in this picture, so this is the actual joint itself. As you elevate your arm up, your sternoclavicular joint is going to slide inferiorly and roll superiorly. As you're bringing your arm down, it's going to roll inferiorly, slide superiorly. Sometimes they say they may use different terms of superior, inferior, or medial lateral glide, but this is what your sternoclavicular joint is doing every time you're moving your shoulder in that position, in the, I call it elevated and depressed position. You also have your protracted or retracted position. So you're going from here to there. Now, the positioning of the joint itself These are just some of the attachment sites here. So it's going to roll. So as I am trying to push myself forward, your clavicle. So here it's going to roll, roll posteriorly, slide anteriorly, roll posteriorly, slide anteriorly. And listen, this stuff is arthrokinematics, so don't feel bad if you don't get it off the first bat. I don't have a problem going through it again later. So then you have the anterior and posterior positioning of the clavicle as well. So in reality, when you're talking about the clavicle position, it never actually goes anterior. It only goes posterior. It only tilts posteriorly and then returns to its neutral position. But going from posterior to anterior, or posterior to forward, is an anterior rotation movement. So, and I just attached some muscular attachments to where the proximal, the sternoclavicular joint attach. Like I said, now I'm only talking about this. Next time I'll go a little bit more in depth with the AC joint. You have your sternocleidomastoid, sternoclavicular and interclavicular ligaments, sternohyoid. I think this is then your subclavius muscle, which we're talking about here. And then you obviously ligament attachments that are significantly important because that's what keeps it stable and prevents instability from occurring. If you have instability from occurring, your clavicle can jump up, dislocate, which you don't want, but that's obviously through with damage in that area. So just a little function or a little bit of names. So you have your anterior, posterior, sternoclavicular ligament. Again, they help. So typically the position of the ligament is what their function is. It is reducing anterior and posterior transitory movement, and is reinforcing the capsule. So that capsule is like the joint space itself, making sure it's not moving. Your costal clavicular ligament is a pretty large ligament between your clavicle and your first rib. Limits elevation and contributes to inferior gliding during clavicular elevation. So making sure that, so that's, these are stabilizing structures. So this is what I was going to draw a little bit here. So the protraction retraction movement typically kind of occurs here, but you're going from here and then here. Okay. When you're talking about the medial, the anterior and posterior glide, it actually is this curved positioning. So it will tilt posteriorly, and then when it wants to go forward again, it's called anterior, the anterior tilt. And then your elevation depression is like that first image that we talked about here. This is your elevation depression view. The clinical significance when you're working out, overhead motions, and especially when people indicate falls. So making sure that when you are working out, I call it like when we're doing any more or less like over the shoulder chest workout. Like I said, when you don't let that weight hit your clavicle. Don't repetitive overhead motion. Not the greatest thing in the world. You don't want to what's what I'm looking for? Overtax that area, overuse. And then typically with individuals in the elderly who have falls and they come in with shoulder injuries. Listen, you're going to look at the whole shoulder joint. I'm just giving you a little maybe if we work on this a little bit, if they're stuck. Because I've seen it, you can do everything possible for your glenohumeral joint, your scapulothoracic joint, your AC joint. Let's look somewhere else. You're talking about 16 degrees of motion that comes from the sternoclavicular joint. It's not significant, but what if it's contributing to it? It's the first 90 degrees of motion. If they have trouble getting that overhead motion, what's going to happen? If they can't get to that 90 degrees, well, let's look somewhere else. So don't forget about other joints that you can look through as you're assessing. I have a lot of the links in the post as well, so you guys don't have to worry about. I didn't have a chance to put them at the end, but that is pretty much it. So that is today's little tidbit lecture. Again, I apologize for being a little bit delayed. Had vacation, had to do some coverages for work. Let me just pause this.